It's helpful to start by looking at how we have previously thought about pain. A little boy falls off his bike, and we sense that he's in pain. We might assume that the pain is purely due to the injury to his knee, or what is called nociceptive input from bodily damage. In the diagram on the right, the old model indicates that a pain signal comes from the body part to the brain, that pain resides in the body. But how does this explain something like phantom limb pain, where the tissues are no longer there, but the person feels profound pain? Or fibromyalgia, where a person has widespread pain all over the body, but they've not had injuries in all of those locations. Let me introduce you to Mary. Mary is 45 years old. On her initial office visit, she reports localized left knee pain for the last couple of months. The pain began gradually and was not associated with an injury. She reports a pain score of 7 out of 10 using a verbal analog scale. She also states she is having difficulty at work because it makes the pain worse. Mary's treatment plan at that time included orders for imaging, physical therapy, and a prescription for hydrocodone acetaminophen as needed for pain. On her return visit, Mary's pain was no better. Her self-reported pain score remained a 7. She was taking the maximum prescribed dose of hydrocodone equal to 60 morphine milligram equivalents per day and having breakthrough pain. She attended physical therapy twice, but reported the therapy made her pain worse. She was informed that the X-ray revealed moderate to severe osteoarthritis. Physical therapy was discontinued, and her medications were changed to a long-acting formula of oxycodone for twice-daily dosing. Over the course of several years, Mary's pain persists. During that time, she received orders for 2 injections in the knee and was subsequently referred to orthopedic surgery, after which she underwent a total knee replacement. Her medication dosing steadily increased, and she is now at 250 morphine milligram equivalents daily. Her pain has spread the length of the left leg and now is in the right knee. She is also having pain in her low back that is spreading up into the thoracic spine and neck. How do we explain Mary's pain when the knee joint itself has been replaced, yet she still has pain? How do we explain the spread of her symptoms? We now know the old model is insufficient to explain pain, and the old way of thinking about pain is inaccurate. That pain is not a bodily experience of nociception alone. We now understand that pain is a complex process that includes input from the tissues and environment, processing at the level of the nervous system and the brain and other systems, which results in output of the pain response. In the case of an injury, signals from the body, like tissue injury, such as when the boy scrapes his knee, send information about potential danger to the spinal cord, where it's relayed up to the brain. That relay of information is only able to tell the brain, hey, there's something wrong down here. It's the job of the brain and nervous system to make sense out of this. Multiple brain centers are involved in any given function and send signals to each other. With pain processing, multiple brain centers contribute to the assessment of potential threat, due in part to information regarding a danger message, or nociception, from the spinal cord. Other biological systems are also activated and contribute to the pain response, such as the autonomic nervous system, the endocrine, and the immune systems. And based on the assessment of threat, the brain and nervous system will produce a pain response to protect us, to get us to pay attention to that part. Let's look at how this works in acute pain first. With an injury, there is a lot of input from the body, sending information about the injury up through the spinal cord to the brain, and the brain then processes that information, determines that in fact there is a threat from the injury, and a pain response is produced. The autonomic nervous system, the endocrine, and the immune systems are mobilized to become involved in the protective and healing processes as well. With complex pain, the brain and body become more efficient at producing pain. Let's look at that. In complex pain, nociception is a less significant part of the pain experience. There may be little to no input from the tissues, like with phantom limb pain or fibromyalgia, and less nociception is needed to trigger pain. With complex pain, the brain and nervous system are often much more involved in a process called central sensitization, or centralized pain. Pathways that process pain become strengthened, and, as in acute pain, there is additional significant involvement of the autonomic, endocrine, and immune systems as well, and thus intense pain is produced. Pain persists due to an elevation of threat, in the absence of, or with minimal input from, an injured or harmed part of the body. The pain process becomes overactive and overprotective. Thus, pain persists, is felt more intensely, and may spread to new areas. Often, the more complex the pain, the more factors and functions involved in the patient's pain experience. Complex pain presents as a myriad of conditions. The person with complex pain might have symptoms of complaints of pain from things that would not normally be painful, like their bed sheets hurting them. They might have excessively negative and irrational thinking about pain. They may have pain which spreads into new areas, is vaguely located or hard to find. They might avoid moving because they're afraid the pain is an indication that they're harming themselves. More severe pain to painful stimulus. Their pain might be associated with stress or a history of depression or anxiety, or occur after significant loss, and it's common to have a history of trauma or post-traumatic stress disorder. And it's common to have other comorbid stress-related disorders. Let's look at how the brain and nervous system modify to develop a complex pain presentation. With complex pain, the brain learns pain. Neuroplasticity means that the brain changes constantly in response to input from your body and from the environment. This occurs with all pain experience. It also means, very importantly, that pain is largely reversible. Let's look further. We used to think that there were specific brain centers to control specific independent functions, thus that there was one pain center in the brain. We now understand that the brain operates like an orchestra, with many centers contributing to one experience. These are some of the functions that contribute to the pain experience. As with any brain process, repetition reinforces the strengthening of brain pathways. In complex pain, the brain has changed in response to injuries, disease, traumatic events, and stressful situations. Pathways are strengthened, and more brain functions have become involved in the pain experience. The brain becomes more efficient at producing pain. In this case, neuroplasticity works against us. Brain processing that has become efficient at the production of pain can change by bombarding the system with healthy input from senses, thoughts, beliefs, memories, emotions, movement, and activity. Just as the brain learns pain, it can also unlearn pain.